Welcome to the Bradykinin Beats, a dialogue with global experts about bradykinin-mediated angioedema. My name is Kenny Robinson, and I'm the head of North America Medical Affairs for Pharvaris. Our first episode, called End of Progression, helps us further understand the full spectrum of bradykinin-mediated angioedema attacks. Hereditary angioedema, also known as HAE, is a bradykinin-mediated condition and will be the focus of our conversation today. The purpose of the podcast is to educate HCPs on the unmet needs in bradykinin-mediated angioedema through expert insights, disease recognition, diagnosis and management, as well as patient communication. I now have the distinct honor of introducing our special guest today, Dr. Rafi Tashan. Rafi, please tell the audience a little about yourself.
Kenny, thank you for inviting me today. As some of you might know, I'm Rafi Tashan, Associate Clinical Professor at the David Geffen School of Medicine at UCLA. By background, I completed my medical school at Morehouse School of Medicine.
Morehouse.
That's right. Followed by a pediatrics residency at Massachusetts General Hospital, and then an adult and pediatric allergy and immunology fellowship at UCLA School of Medicine, where I still remain and teach, along with a clinic in Santa Monica, where we are the referral center for the HAEA for patients. And I'm a fellow of the American Academy as well as the College of Allergy, Asthma, and Immunology.
Thank you, Rafi, for being with us today. Can you start off and explain a little bit about what is HAE?
Certainly. HAE, as the name implies, hereditary, is a genetic chronic condition that is hallmarked by a deficiency or a defect in C1 esterase inhibitor, which is a protein that circulates and helps control the amount of bradykinin at the end being made that is responsible for swelling attacks that these patients encounter through their lives. As the name angioedema implies, it's swelling, but in this case, it's unpredictable swelling compared to someone who has an allergic kind of swell or allergic angioedema, who might recall that, oh, they ate the peanut they shouldn't have eaten, or they took the penicillin they were labeled to be allergic to, or it could be a bee sting that hit them for the second or third time that caused this angioedema bout. For hereditary angioedema, it's autosomal dominant, meaning if you have one copy, you have the condition, and from that point on, each next child or offspring has a 50-50 chance of getting either the HAE-based gene or the non-HAE gene for that particular sequence. And therefore, there's no male to female difference in ratio. It's just as even in its possibility. And it is a rare condition, so making it really difficult to detect, to diagnose, and until recently, to treat.
Are there any specific triggers that elicit these attacks?
Certainly. There are, first of all, known triggers that patients can identify. These can include anything from trauma, say dental work, a crown being redone, a root canal, or repetitive motion in cutting paper, for instance, scissors, or operating a stapler, that kind of local trauma. It could be emotional trauma, an upcoming exam for a teenager, or loss of a job just 2 minutes ago to an adult. And then there are other triggers such as menstrual cycles for women around the time of their menstrual period, to taking a particular type of medication, an antihypertensive such as ACE inhibitors. And then obviously there are unknown triggers. That's where the patient will recall and reflect and say, you know, today is Tuesday. I woke up yesterday and everything was fine. I didn't eat anything different. I didn't particularly do any other activities that could have elicited an attack, and woke up yesterday with a swollen lip or a tongue.
Can you walk us through how HAE impacts patients' lives?
Certainly. By virtue of its being unpredictable, first of all, you've just kind of upended your whole day and potentially the next 5 days. So whether there's a prodrome or not, and the prodrome is the first hint of something's about to go down. So for instance, they might feel a fatigue or nausea, and nausea could signal that there's a GI or an abdominal attack about to happen, or a tingling on the left arm with maybe a skin level rash. I don't like to call it a rash because then even the doctors are going to think, must be a histaminic angioedema or allergic angioedema. Let me give you some antihistamines. That don't work in this particular condition. And these prodromes can hallmark or herald an incoming attack. So once the attack starts, essentially it's just swelling. It could be anywhere in the body, peripherally. It could be the face, the eyes, the tongue, the lips, genitalia. It's not unusual to see a 1-year-old, male or female, having scrotal or labial edema. You could have limbs, left hand. It might seem kind of marginal, but imagine your pilot in a 6-hour flight starts developing left or both hands swelling. Not good. Or your surgeon. It could be feet. Sometimes these patients have difficulty walking all of a sudden. So now they're non-ambulatory and immobile for that attack period. And abdominal ones kind of mimic a bunch of other symptoms like appendicitis, irritable bowel syndrome, and can kind of masquerade under other kind of pretexts. And then laryngeal, which could be potentially life-threatening, where there's asphyxiation as a potential for that attack to progress to. But wherever that attack location is, once it starts building up or progressing, that could take up to around 2 days to complete its progress of progressive swelling. At that point, there's a decline when it's unaddressed, and we call that the end of progression in its natural state. And from that point on, it may take another 2 to 3 days to unswell, and I don't like that term because it's not an active process. It's just a passive resorption through the lymphatics of all the fluid that's been accumulated until the last point, which is symptom resolution. And now that person kind of looks the same way that they did before the attack even started. And so, as you can see from the math, it could take about 5 days, plus or minus a day or two, for this whole attack to take place if it's not addressed or treated.
How does then the progression affect HAE treatment? Can you walk us through that, Rafi?
Sure. End of progression is the point that a patient usually wants to get to, and I certainly want to get to, because that's kind of you've nipped this attack where it needs to be. So as it's building up, whether it's an hour and we've treated it and it's end of progression at that point, it may take 2 to 3 hours to resorb, or unaddressed 2 days where now you're at end of progression and you kind of resorb for the next 2 to 3 days. That's the milestone that we're starting to use now in the HAE world to define where the attack is now taking a better turn, to start coming home. And so that, at least to me with my patients, it has always been the fleeting milestone to say, where do we want to kind of gauge ourselves or grade this attack or the treatment on how well it's addressing this particular swelling bout.
How do you assess that?
It's basically through recall of the patient. And by recall, it could be actively when you're on the phone for the patient to say, okay, just in the last 10, 20 minutes, I feel like I've hit end of progression. What does that translate to me emotionally? A big sigh. Okay, whew, we're good now because now we're unswelling. So that attack has stopped progressing. I hope that makes sense.
Yeah, how do your patients describe it to you? Or what terminology do they use? I'm just curious.
So Kenny, I'll reverse construct that question. I'll give you examples that I've used to hear, which told me what end of progression really means in patient terms. At work, they might still look disfigured, and their colleagues, their coworkers might say, like for instance for you, Kenny, you still look really swollen, like you went into a boxing match, and you might say, aha, yeah, my symptoms haven't completely resolved, but my attack has hit its end of progression. I no longer feel like it's continuing to progress. The best way for me to understand it, because I like to dumb it down for myself and to help explain that to my peers who might not be as well versed in HAE, or the next patient that needs an explanation of what end of progression is the, I call it the pot or pan on the stove example. So imagine you put a pan and you're cooking something and you walk to the next room to watch TV or tend to some other chore, and all of a sudden you may or may not smell the fire, but you certainly hear the alarm, the smoke alarm that just went off. All panic. So this is progression of that burning attack. You come back to the kitchen, and what do you know? The stove's hot, the pan's hot. You quickly submerge it under the water in the sink. Now you've cooled it off. Okay? That's end of progression. The alarm might still be going on. You may still be smelling the smoke, but the attack has, or the fire in this case, has stopped progressing. And it's not till the alarms are completely quieted down and you no longer smell the fire or the smoke in the kitchen that you achieve symptom resolution. So I hope that kind of simplifies it and makes sense.
Can you walk us through in terms of your discussions that you have with your patients about treatment plans and how you kind of get into certain decisions? How do y'all walk through this?
Sure. Well, first and foremost, a well-informed patient is going to be more engaged, and an engaged patient is going to help you in this shared decision-making process so that the outcomes are generally better. Because if the patient's not bought into the treatment plan, then it's someone who's not particularly believing in the process and the outcomes, etc. So if the patient has some say or comprehends and helps you with that decision-making for what kind of treatment to take, when to take it, how to take it, where to take it, how to report it, what milestones to look for, and really to assess it so that when you sit down with them the next time face-to-face, you kind of know where you need to pivot, or if you're doing a great job and you got great outcomes, you continue the course. And so we look at factors such as, are you satisfied with your current treatment? So if it's for attacks, is it helping you efficaciously deal with this attack so that you hit your end of progression as soon as you wanted to, or as soon as possible? Is it safe? We want everything to be safe and not cause harm. And then is it being absorbed, distributing through your body, and the mechanism of action really addressing the root cause of your HAE swelling attack? And so when we have those factors and considerations in place, it makes for better outcomes. It makes for a more confident and empowered patient who actually had a say in their treatment and that path or journey from the time they get an invariable, it's bound to happen for people to have an attack for most HAE patients, and so that they get to that symptom resolution and even earlier to that end of progression that much sooner and more with more certainty.
What final advice would you like to share with those other HCPs who don't treat a lot of HAE patients?
Great question. So not everyone's going to be an expert in HAE, and we don't expect everyone to diagnose, treat, and have great outcomes with every HAE patient. But we certainly want people who are eager to be educated and learn at each new chapter what we have in the best, greatest, and latest in HAE. So I always say, listen to your patient first and foremost, and obviously listen to some of the experts, which are us professing the latest and greatest. And I think we learn a lot from our patients. That feedback is priceless. And when a patient says that they're doing well, that's a big testament on how well, not just me as a physician, but as a community, whether it's the companies putting out the products, the pharmacists, the nurses, the treating physicians and healthcare prescribers. And let's not forget the family members, the coaches, the siblings, et cetera, who've come around this rare disease patient so that they can normalize life. They can get back to what they need to and not have hesitations in their calendar on, maybe I'll make that birthday party for Kenny tomorrow. I'm not sure. No, I want you to be sure, whether you're on a prophylactic treatment or not, that if an attack were to happen between now and your birthday tomorrow, that you're going to still be there.
Thank you, Rafi. One last question. What do you wish your patient would ask you?
That's a great question. I always want, at the end, a patient to tell me, how do you think I'm doing, doc? Because there's a lot to unpack in that question. First of all, as I look into their eyes, for some, it might be a confidence thing. How do you think I'm doing, doc? Where I'll say, the shine's in your eyes, that confidence is in your eyes. I think you're doing great, all right? Or if there's something where we got a shortcoming, let's also address X, Y, because you got Z and everything from A to X covered. Versus someone who says, how do you think I'm doing, in a very timid, hesitant way. And we might say, well, you need to be a little more adherent or compliant with your meds, or let's figure out a better way that can address your needs so that you're more present and not absent in life. Because the HAE in the end should not hold you back from showing up to whatever it might be. And that's my question is, as a patient, I might say, Kenny, how do you think you're doing? And what do you want to do that you're unable to do still, compared to your twin brother or your neighbor across the street? And it might be something as simple and unthought of by the medical community as, what I would do, I would kill to go on a cruise. Oh man, we didn't think about that. And what's holding you back? And you might say, I'm not confident. I know everything's set and I don't have that confidence. And then it might just be, listen, let's go over your treatment plan again. And now do you feel more confident that it's safe, efficacious, and it's going to address your attack quickly and promptly so that you're able to unchain yourself from that anticipatory anxiety and fear and the pain that might arise or disfigurement and embarrassment from a potential subsequent attack.
Rafi, I want to thank you for your time today. We really appreciate it. And this was the first part of this series of the Bradykinin Beats and the first episode of Inner Progression. Thank you again, Rafi.
Thank you, Kenny. Always a pleasure.
All right.